would like to invite you to a little journey into female aesthetic surgery. My name is Mihály Géczi. I work at the Department of Obstetrics and Gynecology at Semmelweis University. My mission is, of course, to aim for perfection in aesthetic surgery with the vision to find the best methods which allow the best functional and aesthetical outcome. Well, in our first steps, we wanted to investigate one of the most progressive aesthetic surgery right now, which is labiaplasty. And in our second step, unquestionably the most desired one, which is aesthetic breast surgery. So let's start with the first one, which was investigating the effect of female genital beautification and rejuvenation on patient-reported outcomes. We started in 2022. Well, many women are not pleased with the looks or the size of the outer genitalia and want it to be modified. And a decade ago, it only consisted by the resection of the labia minora, but now it became an industry. It consists of many conventional and new techniques, combination of techniques. But if we cut to the chase, the whole goal of the concept is to modify the outer genitalia to a better functioning and aesthetically pleasing outcome. The demand for these kind of surgeries, not so surprisingly, grew in the past few years. Year for year, it grows and grows. We can confidently and safely say that these operations end up with averagely a very high satisfactory rate. But are we pleased in the field of plastic surgery with such words like averagely high or very high? No, we want perfection, of course. So, with this intention, we wanted to compare the patient-reported outcomes of different techniques of female genital beautification and rejuvenation, which derived the question, which is the safest and most satisfactory method or methods used in the female genital beautification concept? We looked at women who underwent some kind of operation in this concept. We compared all available and widely used techniques of labiaplasty. Our primary outcome was patient satisfaction, and the secondary was complications, which occurred after the operation. Our hypothesis would be that maybe newly emerged techniques or tools with which these operations are performed by are superior or have benefit over the others. We did our systematic research with the search key shown here. Running down the rabbit hole, we ended up with 50 eligible full texts. And just one more time, to make it easier to understand, so we looked at patient satisfaction, we compared all the techniques to each other, and we looked at complications, which included bleeding, dehiscence, hematome, and infection. We compared all the techniques to each other, and also tools with these techniques are performed by, so energy-based tools and conventional scalpel technique. We looked at 10 different types of labiaplasty. And the result was very interesting. We had a lot of forest plots and a lot of groups and subgroups, of course. In the end, what we saw, that there was no significant difference in the patient satisfaction. So basically all the patients were very pleased with the outcome, not depending what kind of operation, what kind of technique we used or what kind of tool we used. Where there was a little difference, it was the proportion of complications. Because in this case, what we saw, that patients who underwent more invasive techniques or who underwent conventional scalpel techniques had a higher rate for complications. What's our strength was that we included more and higher quality articles than other researchers before, and this was really the first real comparison between techniques and especially between tools. Our limitation was naturally high patient heterogeneity. The patients were, and the whole pool was really heterogeneous. And the other thing was that there is no real generally used scoring system, an accepted scoring system for these questions. So there are scoring systems, but everyone uses something different. It was really a hard job to statistically have results from this. And of course, we had limited limited amount of accessible data, especially in energy-based techniques. In conclusions, patient satisfaction doesn't really depend on the technique, what we use. However, in the case of complications, it does. It does what kind of technique we are using, and it also depends on what kind of tool we are choosing. It's an implication for practice to maybe choose a less invasive and patient-tailored method in this field, and maybe to use energy-based tools if accessible. Implication for research, it would be much easier to compare these techniques and find out if there is any benefit to the newly emerging techniques if we would use a widely used and accepted general scoring system for patient satisfaction. The first project was accepted just a week ago. And allow me to resettle for the second topic, which investigates by all means the most desirable aesthetic surgery, breast augmentation and breast aesthetic surgery. A high number of women undergo this operation worldwide every year. The problem is that most of it, not a problem of course, but in our aspect, the problem is that most women are in the fertile age, which means that their desire for this operation a lot of time interferes with family planning. And nowadays we know that natural breastfeeding has a huge benefit, not only in physiological but also in psychological development by the newborns and later on in life also. Now this raises a huge question. Can these operations, or will these operations impair the breastfeeding function and quality in these women who undergo these surgeries? Because I don't know about you, I want to live in a world where there are beautiful breasts and healthy children. The clinical question derives from this: how do different types of aesthetic breast surgeries affect breastfeeding? We looked at women in puerperium who underwent some kind of aesthetic breast surgery. We compared different types of aesthetic breast surgeries to each other, and in the end we wanted to see what's the change in breastfeeding rate and length. Our hypothesis is that there is an impact on lactation, and also this impact differs between the type of surgeries and techniques we are using. We would say maybe it is advisable to wait with aesthetic breast surgery if there is a family planning on hand, or maybe it would be advisable to reach for some kind of operation which has less impact on this. We did our preliminary search. We ended up with 47 eligible texts, and right now we are doing the statistical analysis, and we hope we end it pretty soon. Our primary outcome, once again, would be the occurrence of breastfeeding, if it happened or not, and of course the length of breastfeeding, because this is also very important, how long these women could breastfeed. And the secondary outcomes would be complications, how much complications these operations are causing. Thank you for your attention, and to infinity and beyond, as always. Thank you. May I answer some questions?
I made a lot of notes. I'm really interested. It's not urology, so for once I'm interested. No, thank you so much. Fantastic presentation, skills, everything, very compelling. I can tell you're going to do great with patients and communication. So bravo for that. I'm looking at the first paper, and the same thing was with you. And the problem with complications is how you score complications. You know, there's standardized scoring of complications. That's the Clavian-Dindo scoring, which means, you know, grade 1, grade 2, because you want to know a complication is not the same on complication. A hematoma may not be the same thing, it may need intervention, may not mean anything. So were those studies that you looked at, because complication is your endpoint, did you have sort of a scoring in, you know, high-grade complication, low-grade complication, because that may mean any and high grade normally?
We didn't. So it was just a retrospective questionnaire in most of the cases, yeah, which asked the patients what happened, and of course they gathered some information about the operations, and it was like a yes or no question. So did this happen to you, yes or no? So there was no scoring system in complications. But because it is, basically it's a very, very minimally invasive operation. So
there's no
in this case, there is no low or high-grade complication.
It would be an outlier.
This is unbelievably rare to see some very huge hematome in this field, or a huge infection, luckily. So this is a very safe operation, we can confidently say. So I would say maybe it isn't worth it to grade it.
Right. The question is also, you said the tool that is used is, dependent. You looked at the different tools. Obviously, I guess most of the people had very little experience with a lot of the tools. So again, learning curve and user friendliness, and a lot of the perception of the patient in aesthetic is the surgeon's impact. The charisma. This is the placebo effect. A lot of things. So I don't know how you're going to ever control for that. And the expectations to have. But I guess also the tools depend on the severity of the it's not a problem, but the severity of the dislike or the issue, or is not that the case?
It is possible to do all kinds of techniques with all kinds of tools, basically. But you're right, because for example, if you're using a laser tool, which is energy-based tool, if you're doing deepitalization, over there you can really impair the function of the nerves and also the blood vessels which go to the labia minora. So yes, sometimes it's a little bit subjective what you have to choose in these techniques. For example, it's not advisable to use laser technique in the case of deepitalization. But basically you can choose from all of the techniques, from ultrasound scalpel, or laser scalpel, because it is possible to do that, but might it have some disadvantages later on.
Let me ask you another question. Sorry to have so many questions, but you said it would be really great to have a tool to measure the outcomes and standardize. Have you come up with a concept? What type of tool? Is it, sometimes it's, you showed pictures, you could do crowdsourcing. Say, this is nice, this is not nice, this is not, but it may not fit the patient's wishes, right? You may not need a tool. Images are sufficient because that's what it is. And you could send it out and get 5,000 people to look at the images and say, this is good, this is not good. But
they did this actually. So there was research. That actually was a multi center research, even in the United States and other parts of the world, where they showed pictures about genitalias to women. And interestingly, they came up with the same result, that everyone finds nowadays. I think it's a little bit because of the informational culture we have. So everyone is consuming the same media material all around the world. So they found the same pictures satisfying, which was smaller labia minora and
But you, let's say, as a scientist, how would you said we need a tool. How would you devise your tool? I mean, that would be a next step for your research, right?
I think it's
to
very
standardize the field.
I think it is very hard to say because of the informational culture and because of what we are consuming in the media, what media finds beautiful. It is really hardly affecting. It is really affecting the women's choice in this field, in my opinion, because, for example, like 20 years ago, without some kind of movies, these operations didn't even exist. So these were really rare operations. I think this need and this desire in women came from informational culture, that they could see that it can be really different.
Thank you. I have for the second, we'll be very fast. For studies that I would expect breast surgery to look at, you would need to compare it to before. How can you look at lactation if there's a high variability in lactation, duration of lactation, quantity of lactation, and I don't know what other criteria lactation would have, and you need to have before and after surgery, but you cannot have before and after surgery because the women are not pregnant. So how can you look at it unless you do a randomized study and you have enough patients allocated, which is impossible.
That's impossible. Setting, right? That's impossible. That's impossible.
You got to have your breasts redone and the other ones don't. And
this is a huge limitation, what you're saying, of course.
So how can you use that endpoint?
We can use questionnaires. We can use questionnaires because a lot of women are choosing to undergo breast surgeries after the first child, after the second child. So yes, we can scramble some data from before the operation, but of course it will be highly subjective because it really relies on the patient's answers, because doing an RCT is impossible in this case.
And memory, I mean how your lactation works.
And memory, of course. So it is highly subjective, and these papers, which we are looking at, are highly subjective in this area. Unfortunately, this is a huge limitation of the area, but I'm pretty sure that we cannot really overstep it. We cannot get around it. It's just how it is.
Was I'm thinking of the second study, if I would be an editor, I would say, is the endpoint you're selling me as such a moving target that it's interesting, but you know you cannot get to that. You cannot answer that question.
Yes, we can. Yes, we can, because what we are really aiming here is not just that aesthetic breast operations have impact on breastfeeding, because you already know they have. What we want to see, if there are different types of aesthetic breast surgeries, for example, subglandular, subpectoral implants may have a different, and what we see now from the analysis, yes, they do. So that's what we want to tell with this article, that yes, some kind of operations are have less impact on breastfeeding, and we want to say that maybe you should choose that.
Okay. Then your hypothesis should be this type of surgery will lead to less, and then you're designing, you're right?
Yes.
But your hypothesis is a different one.
I'm sorry, let's get there. The impact on lactation differs between different techniques. Yeah, this is our hypothesis.
But this is not a hypothesis. This is a question. The hypothesis is submuscular implants lead to better, lower rate of lactation problems or lactation, whatever endpoint, composite endpoint you will have probably, than other techniques.
That's why it's a work in progress. Thank you so much. It was.
Okay. Tamás Vito from Szeged. So congratulations to your nice work and presentation. At the beginning, you mentioned you compared the aesthetic genital surgery to breast surgery. However, the surgeon could increase and decrease the breast size. But as concerned the genital surgery, there was merely the decreasing of the labias. Have you ever heard about the female genital mutilation?
Yes, I did.
It is quite widespread due to traditional regions in the sub-Saharan Africa.
Yeah.
And nowadays there are many refugees from this part in the European Union. Do you have some idea or recommendation for these women?
Yes, there is a possibility to reconstruct labia minora and labia majora, and even the clitoral hood, which is resected over there. It can be repaired with hyaluronic acid, which unfortunately goes away in 1.5 or 2 years, and can also end up with unpleasable effects. And the new way to treat this is the same, like treating the atrophy of these parts of the outer genitals, is allograft fat transplantation, exactly, which has a very good results. Almost 70 or 80% of the fat cells stay over there, and they're staying for a very, very long time. So until now, we can confidently say that this is the right approach. Of course, if the mutilation was too effective, we cannot really repair all the function of the clitoral hood and the clitoris by itself. But at least we can end up with a more better-looking outcome.
Okay, thank you.
I might have missed something, but in your first project, have you only presented data concerning laser labiaplasty compared with scalpel labiaplasty? Are there any other methods, or do you have data on other methods?
Yeah, you have a good eye. We want to include also not just laser labiaplasty, but also ultrasound scalpel, which is the newest and the most promising way of labiaplasty right now. But unfortunately, we didn't find enough data over there. We only find one eligible article, which wasn't enough to include it in this comparison. But actually, this is a good question, because from the journal, they asked the same, that why aren't we including ultrasound scalpel? That's the reason. We have to do research on that. So we should do a questionnaire maybe in Hungary, because I know that in Hungary, some plastic surgeons are already using ultrasound scalpel. Problem is, it's very, very expensive.
Adam Csirzo, Gynecology Department. Thank you for your presentation. My question is regarding your first project. Do you perform this technique in the everyday practice? And if it's yes, can you approve this sentence, the easier is better?
Well, from what I've learned, I'm very young, so I didn't have so much operations right now, but yes, I had a few labiaplasties. And yes, because what I found is exactly in the paper. When I did, for example, a wider veg resection, where we resect a bigger part of the labia minora and we are suturing it together, so this triangle-like, triangle-shaped tissue we are getting out, or we are rejecting. Over there, I had some dehiscences which had to be reoperated, unfortunately, which never happened in any other type of surgeries, which is really inconvenient when you have to tell the patient.
I'm Matt Elias, and I want to ask you that did you thinking about some confounding factors in your second study in connection with breastfeeding, for example, the way of birth?
Of course. In our data collection, we are really concentrating on that. If the type of birth was a C-section or a PVN, and also, which is a very big confounding factor, is that all around the world, the goal, how we try to educate the patients after deliveries are very different. For example, in Hungary, luckily, in most of the hospitals, we are aiming for breastfeeding at least for 6 months and unsupplemented breastfeeding, which is not the same in Germany. In Germany and in France, unfortunately, a lot of times the physician tells and recommends the patient not to breastfeed, which is a limitation for us, and also it's a big problem because we know the WHO really tells us that yes, for 6 months it would be at least advisable to breastfeed the child.
Okay, thank you.
On what grounds do they recommend that in Germany and France?
We don't really know. That's the problem. That's the problem. Yeah, we don't really know, but we have to look into it. And the other thing that a lot of times the patient chooses not to breastfeed because of aesthetic reasons. A lot of times, so they are getting anti-lactational drugs, and this is really harmful.
Well, I think it's just answering on what grounds. I think in Switzerland they have a different family support and child support system, so the woman has to go back earlier to work after 1 month, or so that's why they don't facilitate. Maybe not medical. No, I don't think it's medical. My question would be that, to you, András, I'm Gábor Lesko, is that, do you think that this operation, if it gets very popular, will be advisable to be in the hands of gynecologists, or will it be the procedure of the plastic surgeons?
That's a good question. That's a good question. I think it's better in the hands of a gynecologist, in my opinion, because we are, for example, we are leading deliveries a lot of times. And by deliveries, a lot of times we are experiencing some kind of rupture. So it's in our hand and in our expertise and experience to treat these kind of ruptures. Plastic surgeons are not so familiar with this area. So I would say gynecologists for sure, not just because we want to make some money, but also I think we are more expert in this area.